Good morning. My name is Angela Brathovde. I'm the Vice President of Clinical Services for Horizon Health Corporation. And today I'm going to be talking about the proactive risk assessment. So what is a proactive risk assessment? A proactive risk assessment outlines major environmental areas for a psychiatric safe environment, including doors, toilets, bathrooms, and furnitures. And more than that, it's the ceilings, it's the walls, it's the floor, it's the baseboards. It's also the windows in the doors, the windows on the unit. So anything in the environment is what we look at for our proactive risk assessment. And then all areas identified in the proactive risk assessment are rated for probability of failure, risk to the patient, and system preparedness. And then again, after risks are mitigated. So I'm going to show you the Joint Commission definition, since you're a Joint Commission hospital, for element EC 020101. Elements of performance number 1, the organization implements its process to identify safety and security risks associated with the environment of care that could affect individuals served, staff, and other people coming to the organization's facilities. Risks are identified from internal sources such as ongoing monitoring of the environment, results of root cause analyses, results of proactive risk assessments of high-risk processes, and from credible external sources such as sentinel event alerts. So we're not just looking at the environment. If something goes wrong, we want to take a look at whether it was a user error or maybe it was a systems error. And if it was a systems error, we need to be aware of it so that we can make sure that we can fix it. We put work orders in, we mitigate those risks so that we continue to have safety on our units. The CMS definition of a proactive risk assessment, CMS provides guidelines for conducting proactive environmental risk assessments to ensure the safety and security of individuals served, staff, and visitors in healthcare settings. It's the same thing as Joint Commission. These guidelines are part of the CMS enterprise-wide risk management process and include the following points. So preventive measures. We conduct risk assessments when explicitly noted in the language of the element of performance or when there is a process vulnerability or high-risk procedure. Environmental factors assess for risks from internal sources such as ongoing monitoring of the environment and causes of root cause analyses, as well as from external sources like sentinel event alerts, just like Joint Commission. Safety and security, analyze and use information about system or process failures to improve safety. So we're constantly monitoring the environment daily, monthly, and annually, and even in between to make sure that nothing's broken, or if something is broken, that it is fixed immediately so no one gets hurt. These guidelines are essential for organizations to identify and mitigate risks associated with the environment of care, ensuring a safe and secure healthcare setting. So I'm going to show you some pages of the risk assessment that we did at CGH on the BHU, identifying all the areas, and I'm going to show you all the areas that we look at. This is not the entire proactive risk assessment. The entire proactive risk assessment's about 40 pages because we really want to go into detail about any risks that are on the unit and what we're doing to mitigate them. So I'm just going to show you the first page. That's where you see where the initial was done on February 18th, so about a month ago. And then any updates. If we have any items to fix, any things to change in the environment, we would assign a party who would be responsible and the due date for completion. If a work order was put in, we would put that in there as well, so that we would be able to track what things were requested to be fixed and how long it's taking and whether or not it's being done. So this is the first page. And what you see is the probability of risk, the patient impact, and the current system preparedness. Now, your unit is relatively new, 4 or 5 years old, possibly. And they really did, when they designed that unit, they designed it very well, and they used psychiatrically safe fixtures and, tiles in the ceiling, handrails, all those things that could potentially cause a risk, especially ligature risks on an inpatient unit. So this first page looks at the entrances and the exits. Do we have a sally port? And how does that work? So a person with a badge comes through that set of double doors, and then they are faced with the sally port entrance. Usually your badge opens that first sally port entrance door. If it's a visitor, they would ring the bell, of course. And then the second door, you have a system in place where someone lets you in. And that really mitigates the risk because you're paying attention to who's coming in and who's coming out. There's times when you have someone that might bring something to the unit, supplies, food, dietary type stuff to the unit, and not understand your process and not know that patients can't just walk out. So being able to control that entry and exit is very helpful, especially for people who really don't understand the necessity of keeping the environment safe on a behavioral health unit. So we look at the doors, we look at whether or not any non-emergency exits are monitored, and yours are from the nurse's station, and you're able to unlock those fire doors from the nurse's station, and entrance is controlled, like I said. So moving on to the next, I'm just going to show you several different things. Patient rooms, very important. Your bedroom doors swing out. They have piano hinges on them. So no spaces in between the hinges. That's to prevent ligature risk. However, even though you have caps on the top of your piano hinges to have something slide, like a ligature point slide off, it might not always be effective. So that's why doors need to be open. They need to swing out. And we have those piano hinges to mitigate that risk. It doesn't keep us safe. It doesn't keep your patients safe. We still have to do our checks. The doors should swing out so that their patients can't barricade, and your furniture is not bolted. So you have to be aware of that. So most doors, so the patient room doors have piano hinges. The door hardware is designed to prevent an anchor for hanging. But again, people can be very creative and find ways. So we still have to make sure that we look at those doors to make sure they're in good operating order, that there's a cap on the door, that we make sure that there's a cap on the door, and that we keep those doors open so that we can see what patients are doing inside. We also look at the HVAC grills that are either in the ceiling or on the floor or are maybe, along the wall. Your HVAC grills have very small, non-loopable perforations because even shoelaces or dental floss that can be smuggled in could be used as a ligature risk. And if the patient can be creative and get that piece of dental floss into those holes, that can create a ligature point. Again, we can look at weight and whether or not some of those things hold weight. It still is a risk, and we still have to be aware of it. The other thing that's on this list, on this page, and of course there's more to the patient rooms, are the fire sprinklers and the smoke alarms. So yours are flush to the ceiling, so they would be difficult to get to or to break. The other thing is that the ceilings are high, so they're quite high. Unless a patient's standing on furniture or standing on something, they might not be able to reach that fire sprinkler. So that's one of the things that we look at as well. Smoke alarms or the strobe lights that you see sometimes are ligature risks. It depends on how wide the frame is on that fire alarm. So again, unless it's covered with a Lexan cover plate or enclosure that locks, that is a ligature risk because a patient can get something narrow around that to create a ligature point. It'd be hard to do, but it can be done. So again, we always have to be aware of those types of things, all the things on the walls that we don't really pay attention to unless it's a psych unit, and we don't sometimes realize some of these things are potential ligature risks. Patient bathrooms. Now, your bathrooms are very well designed. You have those soft suicide doors. They look like gym mats, but they provide privacy as well as being able to see legs from the bottom, and they're a little shorter on top, so you can see ahead if you need to, if patient's standing up in the bathroom. Bathrooms and patient bedrooms are the highest risk for suicide, and those doors really help prevent that attempt in the bathroom. So those soft suicide doors are hanging in the bathrooms. The ceilings in the patient rooms are solid without stains or holes. So we also look to see if there's any infection control issues. If you see a spot on a ceiling, whether it's a hung ceiling where it's the hung ceilings that are with the frames, or a solid ceiling, if there's a stain on it, that's an infection control issue. Could cause an infection with the water, can cause issues. So we need to let environmental services and facilities know about that. So it's something that we would look at anyway. What else are we looking at here? Vents flush to the ceiling or wall and might have a mesh screen, and yours do, to reduce the size of holes, to reduce ligature points. Surface mounted lights don't present an anchor point. They're flush. And they're inset into the ceiling. So we wouldn't see any ligature points. The one thing we would have to pay attention to, and it's not on this form because I just took a snapshot, is the tamper-proof screws. Are all the tamper-proof screws in every room? I had a boss tell me one time, you need to know exactly where every screw is in every room. And you know what I did? I went around and I took note of any tamper-proof screws that weren't tamper-proof. Maybe they're Phillips head. It was an accident. Somebody put the wrong screw in, or that fell out, or it wasn't put in to begin with. So if there's a hole, that it could be used as a ligature point. If it's next to another hole, people can be really creative. The other thing I wanted to go back to as far as patient rooms and bathrooms, patient rooms, the furniture's not bolted, but it's heavy. So what patients could do, if not supervised, every 15 minutes or even more if necessary, tie a knot in a sheet and wedge it between the wall and the bed, or you have those big bookcases on the unit, wedge a knot, and then the patient can lay on the ground and what's called alligator roll, tie something around their neck and roll to the point where they cut off their circulation. Same thing with door handles. And that's why we have the kind of door handles that we have. You cannot put something around them because it would slide off or it wouldn't hold that weight. People have died by tying ligature around door handles and then tying the other end around their neck and then just leaning forward. There was about 10 or 15 years ago, teenagers were doing this thing called the choking game. And that's what they were doing. They were tying things to the end of their door handle or their beds, tying around their neck, get on the phone with somebody, and just as they're about to pass out, the friend would wake them up or tell them to get up. Very dangerous game. Many kids died from that. But those are the different ways that it's not just hanging from a high point. Patients can lay on the ground and strangle themselves, or they can lean forward from a door handle or a ligature point that's low enough, and alligator roll. That's why our toilets are enclosed. That's why the toilet seats are not movable. It's all one piece in the toilets. That's why any of the hardware is covered. And then when we look at the patient's sinks, they're also enclosed. You also see the faucets are rounded so that it doesn't hold a ligature point. However, underneath sinks sometimes, and if that enclosure is not flush to the sink, you might see holes at the bottom of the sink. Every sink has one, which means someone can put a ligature in there. They can thread a piece of sheet in there, pull it out the other side, or tie a knot to it and use that hole to as a ligature point to then alligator roll on the floor. So all of those things are important. Let's go to the next one, the day room. So this looks a little small, but the furniture in your day room is quite heavy. It's hard to move. The chairs are quite heavy as well, but they do have ligature points. Each chair does have a ligature points, as well as the tables, if the pedestals on the tables. They're still heavy. They can't be used to barricade or throw. However, there is some risk. And when patients go into that day room by themselves with the door closed and there isn't staff in there, there is always a potential for risk. So really, someone should be in that room when there's patients in the room. Eating utensils are controlled, and you do that. You do count the number of utensils before and after meals when the patients leave the day room. So that's good. Bookcases, I don't think there really are any bookcases in there. There's cabinets that stay open. They're not locked, but there are supplies in there for patients that are not really dangerous. Markers, I think maybe crayons and some coloring pages. So those are fine. Any kind of activity supplies are locked up in that storage closet at the end of the unit. So those kinds of items are controlled. I know Michelle does a lot of really creative groups and uses lots of supplies. So she really controls the use of those supplies and how those supplies are used. And I'm sure when the group is over, she's checking to make sure she's got everything, that no one took anything before the group is over. Your televisions are enclosed, which are great. And the appliances for food, the nourishment center, it's in a separate room. A lot of my units have their nourishment center right in the day room where the patients are. So it's not as controlled as you are able to do. They're not as able to control the snacks and the use of some of these appliances as you are, because you have a separate room. So you can control that much better. I'm just going to show you the seclusion room. It's really important. All doors, including glazing materials, are constructed to prevent breakage or damage. So any doors with windows in them should be non-breakable with glazing material set in the doors. Oftentimes, and I have to look on your unit again, when those glazing material, when the glass is set into the doors, sometimes those aren't tamper-proof screws. So we need to take a look at that to make sure. No protrusions on the walls or on the doors, because again, that could be used as a ligature risk. We do have, I think there's visual in those seclusion rooms, not audio. You cannot seclude and restrain someone simultaneously without audio and visual. So if you don't, and most places don't, then a person has to be one-to-one in front of that patient while they're in seclusion, looking through the door. So there is no simultaneous seclusion and restraint. There is a convex mirror in that seclusion room. There was a blind spot in there. So Serena had a mirror put in there, and that convex mirror is made of non-breakable material. It's secured with tamper-proof screws. And again, those ceilings are high, so it's difficult to get onto that, to get to that ceiling, to reach the ceiling without standing on something. And you do use a seclusion chair, not a bed. So that's another, that helps with mitigation because that patient can't be high. The light switches are on the outside of the room. It's important to be able to see the patient. Plus, light switches could be a ligature risk. So that's the seclusion room area. And again, hallways, We always have to look at the doors. So any doors that aren't patient rooms should self-close and self-lock. The only one that doesn't on your unit is the exam room. So we really have to pay attention. That doesn't auto close and auto lock is the exam room, because we got to pay attention to make sure that door is closed and locked if that room is used. And that room was used this morning. So I'm sure the nurse that was doing the admission ensured that the door was locked once they left the room. Another thing we do is an annual environmental and risk assessment. And this is more, I think, a working document. The proactive risk assessment is a working document. It should be a working document. But this one, we usually do this with facilities. So if we set a time annually to walk the unit, facilities, infection control, maybe quality and risk, take a look at some of our ligature points, some of the issues on the unit. Again, your unit is a relatively new unit, so you have really good psychiatrically safe furniture and fixtures and appliances. However, things break down on a unit or things get damaged, either due to patient use or patient, getting agitated. So we look at each one of these things, and a lot of that is on the proactive risk assessment, but a lot of it also has to do with making sure the environment is clean and things are being fixed and maintained as they should, because we don't want anything to happen that could cause a risk if something was broken or damaged. So again, we'll go through this list. We'll create corrective action or work plan for any issues that we might need to address. So I check no on the bedside tables because the furniture is not bolted to the walls and could be used as a barricade if a patient got really creative or really agitated. Your bedside tables are open. They're like shelves. There's no drawers. There shouldn't be drawers because that's a ligature risk. And I think the reason why I check no is because it's not attached. So some places will attach their bedside tables, and then if there's a gap around the edges, they might fill it in with pick-proof caulk so that patients can't work that caulk and take it out. So same thing with pictures or any kind of like paper towel holders or things that have edges around them that could be pulled away. You have to be careful with the paper towel holders, though, because if you caulk around it, you might not be able to open it. So again, looking at whether or not something's a risk and what we can do to fix it, to make sure that we understand that it's as functional and as safe as it could be. So and this is several pages, this environmental risk assessment. And usually what happens is once we complete that, we generate work orders because we're with facilities. They see what has to be fixed and why, because a lot of these things are safety issues. And it usually helps in getting things fixed and maintained as we need to. So the next thing I'm going to talk to you about is daily environmental rounds. We're going to be moving to this form in a few weeks. Serena's going to be educating the MHTs on doing the rounds. You do rounds now. The MHTs do rounds now, the BHTs. But this is a little more formal, and we would want everyone to go in every patient's room to check to make sure there's no food items or cups. There's nothing taped to the walls. That's a Joint Commission issue. We don't want to see tape. Whether notices are laminated or put in page protectors with double-sided tape, that's better, but we don't want to see items taped to the wall. No contraband in the room. So if someone was allowed something, it needs to be returned, and we need to make sure. So rounding should be done in the morning within 2 hours of the shift starting. Looking at the electrical plates, the receptacles, are they intact? Light fixtures, are they intact? Windows, sprinkler heads, walls intact without need for maintenance. because if we do see something, we need to get it fixed right away. Excess linen removed. We don't want patients to have excess linen because that could be a ligature risk. The bathroom's clean, and the bathroom and suicide shower door is in place. Hygiene items are stored correctly. So if there's a time where hygiene items need to be put away, then during those environmental rounds, it might be too early at that point. They might use their items until maybe 9 o'clock. It depends on your routine, but those should be put away as well. And you do have containers for all your patients' belongings and for their hygiene supplies. So it should be easy just to put those things away. Doors are correctly opened or closed or locked. So we know that if a patient's, correctly open, closed, or locked. So if the patient's not in a room, or if there's no patient in the room, the door should be locked so patients can't go in. And the BHT should be checking all doors, and they do every hour. I see them going around checking all the doors, but as they're doing their 15-minute rounds, they should be checking those doors anyway to make sure they're locked and closed appropriately. No gloves and waste baskets. Patient can swallow those, and then surgery is necessary. So we shouldn't put things that we're using, staff might be using, do a glucometer check. Make sure you take that glove out with you when you take the glucometer out with you if you're in a patient's room. None of those things should be in the patient's rooms or in their garbage can. The other thing about waste baskets, it's better if they're collapsible. Some units just use paper bags and then they collect those. But waste baskets, if they're sturdy enough, could be stood upon to create a ligature, for a ligature point if they want. So Serena said that your trash cans aren't collapsible, but they're not really sturdy. So again, pay attention to that. Where is that waste basket in the patient's room? So let's see. Okay. And then this is the second part of it. It's just one page, each shift. Floors and hallways are clean and clear. No chairs in the hallway. Unattended cleaning and maintenance carts or tools are removed. And I do notice that when maintenance comes, they leave their cart either in the sally port or beyond. It should not be on the unit. Same thing with housekeeping. Either they should have a locking cart or it should not be on the unit. Broken medical equipment removed and reported. All storage areas, exam rooms, med room, med window locked. And you do have blind spots where the med room is and also on the other side of the nurse's station where the staff lounges. So again, really being aware of those blind spot areas and where patients might be able to hide or be out of view of the camera. Same thing in the day room. They could be sitting where they're out of view with the camera and then you wouldn't know what they were doing. So that's why it's important to be in that room. Day room and group rooms checked and cleaned, all counters wiped, garbage not full, all furniture arranged properly for day group room consult rooms. The refrigerator's clean, expired food is disposed of, no bedding outside of the patient's rooms, no unsafe clothing or jewelry, socks need to be on, no chairs in blind spots in day rooms, and all patients should have their name bands on. So we really shouldn't be scanning the patient's band if it's not on the patient. We should be scanning the patient. And then if there's any issues that have been identified during these daily checks, then you would write down what those issues are. You could also use the back of the form if there's a lot of issues. And then what corrective action was taken. So was the item removed? Was a work order completed? Did you notify Serena or the charge nurse? So, and that's for both shifts. So that would be done daily and given to Serena every day so that we can track the environmental rounds. We're not just looking for cleanliness, we're looking for patient safety. The other thing I want to point out too, as MHTs and BHTs are doing their environmental rounds, is vinyl baseboards. Some units have the flooring that goes all the way up that looks like a baseboard. Some have separate vinyl baseboards. That's important to pay attention to because if there are breaches in that vinyl baseboard, that patient can work that thing and take it off the wall and use it as a weapon. So that's something that should be looked at as we're looking at the floors and the walls and the ceilings, the baseboards, the doors, make sure they're locked. So this is coming. Serena will announce when it's coming, and we can go over it again if you need once we roll this out. The last thing I wanted to show you is that you have a lot of policies related to your environment of care. That's how important it is. And really, the purpose of the proactive risk assessment is that when a surveyor shows up, you have something to hand them and say, here's our risk assessment. We know exactly where our risks are, and we have mitigated them. So every screw, every door handle, the vents, we know what's on our unit and where we need to pay attention. So your policies related to your environment of care, your locked behavioral unit, health unit, your access, the Sally port, the way you allow people to come in, that they can only be buzzed in by staff, so they know exactly who's coming in and out, the behavioral health environment, and looking at safety risks in the environment, patient valuables and possessions, hazardous items, illicit items, patient searches, search of unit, patient room, packages and mail, and unit, patient, and environmental rounds. So I encourage you to refer to those policies if you need to. Everything we do has a regulatory perspective and a regulatory requirement. So this is the purpose of the proactive risk assessment. If you have any questions, please feel free to reach out to me. I'm happy to answer questions, and I really appreciate your time today. Thank you for joining, and I'll see you on the unit. Thank you so much.